Hi there, it's Dr. Ryan, and today I'm going to do a quick video on a question that's been posed to me by some of my patients, and that is, does TRT provide some form of protection, confirm some form of protection against COVID-19, or if you do get infected with COVID-19, does it make the illness a little bit better, its severity a little less terrible? Right? And that's a good question. And the real answer is we're not entirely sure, but there has been some research that might shed some light on that. And so why don't we go ahead and take a look at it? So the first thing I want to look at is, let's talk a little bit about COVID-19. And so the CDC has some excellent information about the virus, both in terms of a weekly tracker in terms of cases, and then just a nice overview. The one that's geared towards healthcare workers, it may be a little bit difficult to work through, but it's actually quite it's well written. And I think for the layman with a little bit of persistence, someone who's not in the medical field could definitely get through it. But just to give you, a basic overview about COVID-19. So COVID-19 refers to a specific coronavirus, and coronaviruses are part of a large family of viruses that typically cause respiratory infections in humans. They also infect animals, of course. The illnesses can range anywhere from the common cold to more severe diseases, such as SARS, severe acute respiratory syndrome. COVID-19, of course, was identified in Wuhan back in December 2019, and started to become started to become more of an issue in March when large amounts of people around the world were infected with it, and it had a very quick infection rate, and it also had significant mortality and morbidity amongst certain age groups. And obviously, it's transmitted much like the rest of the coronaviruses through respiratory droplets, so through sneezing, coughing, and that's why physical distance of at least a meter is recommended by the World Health Association. Here, the CDC recommended at least 6 feet, and then, of course, the mask that we're all encouraged to wear to help prevent transmission of droplets. And then, of course, many symptoms associated with it, very similar to what you probably already heard: fevers or chills, muscles, body aches, even GI distress as well. And of course, the illness severity, which can be range from just mild, or many patients are asymptomatic, to those that have to be hospitalized and many times even intubated. And so again, there's plenty of information here that you can look through, just get some ideas about it. What's also kind of interesting is the CDC has a data tracker and a weekly review where they kind of go through some of the updates that the FDA or the CDC or some of the larger companies involved with the vaccine have put out there, as well as reported cases. You can see that there was a large spike back in January. You can click on this right here. There's a large spike back in January of last year, and it's thankfully dropped down. And it appears that the amount of hospitalizations, of course, has dropped as well significantly since January, which is a good thing. But anyway, back to our original question. So does TRT confer any sort of benefit in patients who get COVID-19? Well, that's kind of a difficult question to answer, but there are some studies that maybe indicate it might, right? So here's a study that was published in the Journal of Andrology, July 2020, and it kind of proposed to ask the question, why does COVID-19 tend to kill more elderly men than women? Why does it cause more morbidity and mortality in men than women? And is there a potential role for testosterone? So I download the article, and let me go ahead and stop my share here and switch over to the article. And this, of course, was an article that came from the Keck School of Medicine over at USC in California. And as I mentioned before, it aimed to find a hypothesis as to why COVID tended to affect elderly men much worse than it did elderly women, or significantly worse, right? And so it started by just pointing this out, that the mortality rate seemed to be higher in elderly patients than those between 70 79. Fatality rate has been something like 18.5%. And really in the US, the fatality is concentrated primarily among those above the age of 65. So from 65 to 85. And it seems to be there's a definite predisposition for men to have worse outcomes. In China, 60% of the COVID-19 patients were male. In Italy, 70% of those who died were men. 73% of the ICU admissions in France were men. In Norway, it was 75%. And in the US, at least 60, if not more, of the deaths were male, right? And so it started out by talking about with elderly men, male hypogonadism, known as late onset hypogonadism, is pretty common. It may be secondary to primary hypogonadism, where the actual Leydig cells, the cells within the testicles, tend to reduce testosterone formation, and maybe secondary hypogonadism, where GnRH, the hormone released, or LH released by pituitary, the hormone GnRH, the hormone released by the hypothalamus acting on the pituitary, or LH and FSH released by the pituitary, may be reduced, causing less stimulation of the Leydig cells to produce testosterone. Or it may even be mixed of both, either central and so primary and secondary. And regardless of the cause, it does tend to cause a pretty significant decline in testosterone, somewhere between 20 to 50% of men over the age of 60 having significantly reduced levels, right? And it's characterized by loss of libido, erectile dysfunction, loss of muscle mass, and of course, a greater likelihood of metabolic syndrome and cardiovascular disease. And so the paper did note that older men in general tend to be sicker, tend to have more metabolic syndrome, obesity, diabetes, and that is correlated itself with low testosterone. So it's kind of like a chicken versus the egg phenomenon. Does having, being obese, having diabetes, does that cause you to have low testosterone, or does low testosterone predispose you to having those conditions? And I would actually argue that lower testosterone can lead to some of those conditions, because there have been some studies have shown that prostate cancer patients, many times we will treat them by reducing reducing androgen. There are certain medications we'll use to block testosterone or block androgen receptors, and they actually develop metabolic syndrome, so higher blood pressure, higher waistline, worsened lipid panel, so increased LDL, worsened fasting blood glucose, and worsened triglycerides. And of course, it also appears that if patients are hypogonadal and they do receive testosterone, it's been shown that that can improve insulin resistance, obesity, and dyslipidemia. So abnormal triglycerides, etc. And they then went to go ahead and talk a little bit about the hormonal changes in elderly women. So with women, what's kind of interesting is serum testosterone levels also decline from 20 to 40. So there's a pretty significant decline, about 50%. And then after menopause, so when they go from 60 to 80 years old, there's actually an increase in serum testosterone levels. And the extent is kind of variable. Some women have more of a testosterone boost than others, but it has been noted. And I guess what's more key is the androgen to estrogen ratio seems to be reversed, so that because estrogen for sure tends to drop significantly after menopause for women, but not so much androgen. And this change in ratio oftentimes is linked to some of the side effects that you'll see that postmenopausal women will have to deal with, such as male pattern baldness or potentially facial hair growth, right? Also of note, they talked about how the immune system. So ideally, with your immune system, it's designed to to help protect the body against certain antigens and pathogens, or sorry, pathogens such as bacteria, viruses, etc. And ideally, you want it to be very specific and allow it to go ahead and act on that particular pathogen by itself without hurting other tissues. However, it's very possible dysregulation can occur, and this is very common, particularly in patients who have allergic reactions. It's just a very high, um, overly active immune system, and autoimmune immune disorders such as rheumatoid arthritis, lupus are just manifestations of a immune system gone haywire, right? Aging itself is associated with a decline and remodeling of the immune systems to the point where you get elevated systemic inflammation at baseline, right? And so you'll get these elevated levels of certain cytokines, which are very potent in terms of uh, increasing your immune response. And these are interleukin 6 and tumor necrosis factor alpha. And so as we get older, we tend to have higher amounts of these cytokines circulating around anyway. And there has been quite a bit of data that has shown that testosterone itself tends to suppress immune cell activity and tends to reduce these inflammatory mediators and cytokines. There have been certain studies of seen that lower testosterone levels have been shown to be associated with higher rates of infection related hospitalizations in patients with in male hemodialysis patients. TRT administration in aged male mice seems to decrease mortality and reduce disease severity regardless of how much pulmonary inflammation they had. And lower testosterone levels in younger men has been associated with the low-grade systemic inflammation, owing primarily to potentially higher levels of IL-6, which was going to be higher in individuals who are older. And this actually has been noted in studies that interleukin 6 is elevated in late onset hypogonadism, so in elderly men, right? And it could be causing some of the issues that are associated that I see in our clinic with testicular hypofunction, loss of libido, mental fatigue, weight gain, increased blood pressure, poor biomarkers, almost things that kind of resemble chronic inflammatory disease, right? And then also of note, another important cytokine, TNF alpha, also is a very potent cytokine, has also been shown to be reduced by TRT, by testosterone replacement therapy. So a good thing, right? And so, all right, so testosterone, as we know, just reviewing, is lowered in elderly men via late onset hypogonadism through multiple modalities. In women, it appears that testosterone levels may actually increase, particularly in the 60 to 80-year-old group. And it appears that testosterone has a modulatory effect on inflammation and actually reduces some of these harmful cytokines from being released. And what we've found in recent treatment of patients who've had severe COVID-19 sequelae, and one of the most severe sequelae of COVID-19 is something called ARDS, or acute respiratory distress syndrome. What we found is that usage of certain drugs to decrease IL-6 seems to really improve their outcome. And one of those drugs is tocilizumab, which is a monoclonal antibody that's an anti-IL-6 therapy. It basically blocks IL-6, interleukin 6, and it seems to really improve patients who are in the throes of a hospitalization with COVID-19. And then going to ARDS, so acute respiratory distress syndrome. So that's basically, briefly, just a very it's a terrible situation where you have extreme inflammation in your lungs and the alveoli. There's a lot of breakdown in those little air pockets in the lungs, so gas exchange can occur. You can't really ventilate, you can't get rid of CO2, you can't really oxygenate very well. And so in many cases, these patients have to be intubated. And in medicine, we call it supportive therapy. We intubate them and We essentially just try to stabilize their vital signs and treat underlying infections with antibiotics, and just kind of hope for the best, and then watch them over time. And many times when you develop ARDS, your chances of succumbing to an illness get much worse. And so that's something that we definitely don't want to get towards. And it has been shown that ARDS is linked to higher IL-6 levels, right? And so ideally, if you can modulate that, you can reduce the incidence of ARDS and potentially reduce the mortality for diseases that predispose one to ARDS, which COVID-19 is one of them, right? And this has been shown actually in a couple of studies. So that ARDS was directly linked to high IL-6 levels, as well as low testosterone as being part of the pro-inflammatory profile associated with ARDS, and how TRT can actually reduce certain inflammation, particularly that found in asthma. So the fact that it has these immunomodulatory effects can be put to good use. And then finally, what's also interesting about SARS-CoV is that it tends to bind to certain host cells. There are certain cells within the body that have a preponderance of being affected, a predilection to being infected by COVID-19, and that would be the heart, kidney, testes, and lung tissue, of course. And we all are familiar with the lung tissue and then the respiratory issues that COVID tends to cause, right? But interestingly, it also infects the testicles, and so it's owing to this ACE2 enzyme receptor found on those cells, and it's found in high concentration in those tissues. The virus tends to bind to that, and so what that means pretty much is it will infect the testicles and actually affect Leydig cells. And Leydig cells, as I mentioned earlier, are the cells responsible for testosterone production. So not only do you have these elderly men who have lower testosterone at baseline, but COVID can infect those cells producing testosterone, which would lower it even more, which could probably link to even worse outcomes with COVID-19. So the article at this point just ends up stating that, yes, there are other factors that may explain the difference between mortality and morbidity with women and men. One of which is that estrogen does have an effect on the immune system, but they do argue that women, postmenopausal women, don't tend to have the estrogen benefit that their younger counterparts do, and they don't seem to do quite as badly as men, right? And there have been some studies that have shown that increased estrogen levels have actually worsened outcomes in men with septic shock. There have been a few studies that have shown that. So maybe estrogen is not the answer. And then, of course, gender related lifestyles could play a role. Smoking is more popular among men throughout the world than women. However, the evidence linking smoking and severity of COVID-19 so far is weak. It's likely that they're linked, and it probably doesn't help by any means, but it's not. There isn't enough research to suggest it's super strong. Okay, so those were the conclusions of this paper, which was kind of interesting. However, what would be best if there was actually an actual study which looked at patients who had COVID-19 and that were on TRT and saw if they had better outcomes. And so I searched around, and actually there was one that was published recently. And so you can stop my screen share again. So over here, and actually this is kind of an interesting article that kind of displays some of the effects that testosterone has on the immune system. It was talking about how androgens modulate the pathophysiologic pathways of inflammation. So it's done at Boston University, and it kind of had these great graphics that kind of outlined the complexity of the immune system and all the different cells and cytokines involved with it. You have pathogens that come in, get on the cell membrane, and they cause a whole segue of reactions that cause these factors to be transcribed in the nucleus of your cell: IL-6, IL-8, IL-10, TNF alpha. Remember, we talked a lot about interleukin 6 and tumor necrosis factor alpha, and then some of the effects of inflammation in terms of how it causes white blood cells to move, migrate to those areas in a process called chemotaxis, and some of the things that white blood cells do that ostensibly help but can also hurt because they're not necessarily selective against a pathogen, like a neutrophil releasing reactive oxygen species or active nitrogen species, which are very potent and can kill pathogens, but also kill healthy cells too, right? And then of course, just the differentiation of T cells, helper T cells, and release of multiple types of cytokines, which again are pretty potent potentiators of the immune response. And then you can see that testosterone seems to cause downregulation or actually decreased proliferation of many of these white blood cells and decreased release of these cytokines, which, as we mentioned, can be a good thing in COVID-19 when the response of your immune system to the virus may be a little bit too robust, particularly in certain individuals. So anyway, going to that study, so here's a study that was published in January of 2021 in the Journal of Sexual Medicine, and it actually looked at patients who were infected with COVID-19 and who are on testosterone replacement therapy. And so what they did was they did a retrospective chart review, and they looked at 32 men diagnosed with COVID-19 on TRT, and then matched them to 63 men diagnosed with COVID-19 not on TRT. They looked through 3,000 charts. I think this was over at the Henry Ford system in Michigan at a large medical hospital. And what they found, they went ahead and compared the two in terms of comorbidities and points such as hospital administration, ICU administration or admission, whether or not they were placed on a ventilator, whether or not they had strokes or pulmonary emboli or thromboembolic events, and of course, the mortality. And I actually downloaded the paper and researched it. Unfortunately, there were differences, and they were many of which were positive towards patients on TRT. However, they were not statistically significant. So in other words, for those individuals who are familiar with stats, the p-value was not less than 0.05, and you couldn't technically reject the null hypothesis. However, I suspect had this sample size been a little bit larger, it might have been, right? And there was a difference. I think the p-value was for ICU admission, I believe it was 0.0 or 0.07. I believe for ventilator usage, it was like 0.1. So again, not statistically significant, but maybe with a larger group, it might have been, right? The one thing they did note that is it's not associated with a worse clinical outcome by any means, right? So at the very least, it couldn't hurt, right? So I guess that was kind of a long-winded way of saying that we're not entirely sure if TRT can confer strong immunologic benefits. It seems like it does modulate the immune system. It seems like in theory it should help. The one study that I found really didn't show a statistically significant difference between the two, although if you look at the data, they did fare a little bit better. And then I guess the main thing is we'll just have to wait and see what some larger studies to see if it really plays out. But I certainly don't think it would be a bad idea to continue your TRT therapy, and it certainly may prove some benefit to those individuals who do unfortunately get COVID-19. Okay, well, that's pretty much it.